record button and share my screen so that you can see the slides. All of you should have full access to the Google Drive and should be able to get all the videos as well as the Q&As that we are posting after every session. Chido, are you able to see my slides?
Yes, I can see them, but they're not in full view yet.
Now?
Okay. Yes.
Okay, now?
I can see them now as well as your notes, but I think it should be fine.
Is this better?
Much better.
Okay, all right. So bias. The first thing I want to say is when we in epidemiology talk about bias, we're not accusing researchers of being biased or dishonest. That dishonesty, fraud, all of that is not what this is really trying to capture. Yes, there are dishonest researchers. Yes, there is fraud, but that's not what we are trying to say here. Bias is a very real problem that even the best epidemiologists in the world will have to deal with. And I guarantee you, every study that I've ever done has some bias or the other, okay? And I often have to be aware about them. And when I write about them, I often write a limitation section in my paper to communicate what challenges I have faced. And that's the honest way of writing and reporting, okay? Every single person study has some bias or the other. It's only a question of how bad is it and can we meaningfully address that or adjust for it is the question. So you've already seen this slide before, but I still think it's really critical that you understand, okay? So let's say we are looking at the association between, say, tobacco smoking and COVID-19. Whether tobacco smoking is harmful, tobacco smoking is protective against COVID-19, nobody knows, right? But let's say that's the true causal effect we are trying to study. And while we are studying that in any epidemiological study, we do a study, we see something. The first thing we worry about is this just chance? Is the association we are seeing, positive or negative association between tobacco smoking and COVID, is that just random error? Purely a fluke occurrence because of the way we collected a sample from a bigger population. And to address that, we'll use things like p-values and 95% confidence intervals to rule out the chance association. Then we ask, is this due to something called confounding? Okay, and confounding is one type of bias. Okay, confounding is a very important type of bias, and I'll talk more about confounding towards the end of this lecture. And then we ask whether what we are seeing is purely because of information bias or selection bias. So selection bias, information bias, and confounding together falls under the term bias in epidemiological research. Okay, bias in epidemiological research comes in three big types. Selection is how we select people into the study. Information bias is how we measure things about them in the study, the instruments that we use. And confounding is whether whatever we are seeing is distorted by other variables that we've not quite adjusted for. And of course, there are other potential problems as well, but I want to just focus on bias in this particular lecture, okay? So bias for us in epidemiology is selection bias, information bias, and confounding. And that's exactly what I'm showing here. So we first speak about error, right? All epidemiological research has two types of error. There's random error and there's systematic error. Random error is chance and systematic error is bias, right? Now, what's the difference between random error and systematic error? Let's say you have a weighing machine at home and you stand on the weighing machine every day, you get a slightly different answer, right? Because your body weight fluctuates, the weighing scale has its own error, and random error can either overestimate your weight sometimes or underestimate your true weight sometimes. It has no inherent directionality, okay? But let's say your weighing scale is always starting at 5 pounds or 5 kilograms higher than the true weight, then you have a biased weighing scale, right? It's already twisted the knob or the needle away from the truth. So you consistently going to overestimate somebody's weight because the weighing scale is already biased in a certain direction. Systematic error means there is a directionality to it. You can predict that this is either going to underestimate the association or overestimate the association. That is why we call it systematic error. Okay, systematic error is also called bias. And we also say that bias is any process, is any stage of inference which tends to produce results or conclusion that differ systematically from the truth. And obviously, when you measure an association, let's say a relative risk or an odds ratio, there are two things you can ask about that. How precise is that odds ratio? In other words, is your confidence interval fairly narrow? And that is addressing the problem of random error. Larger the study, lower the random error, more precise the risk ratio or the odds ratio or the prevalence. And you reduced your scope of random error or chance. That's why large studies are better than small studies. But you can have a gigantic study that is still biased. Bigness of a study or largeness of a study does not guarantee absence of bias. You could have a humongous study on a completely biased sample and you end up with the invalid result. So the big sample size does not protect you against bias. Big sample size protects you against random error, reduces the variation, makes your confidence intervals less. So in epidemiology, we separate two things. Precision is the confidence interval narrow, and if the risk ratio or odds ratio or an incidence, a precisely measured number. More precise it is, the better it is, okay? And that comes from a large study. Small studies will always produce imprecise estimates, wide confidence intervals. We can never quite tell what is going on because there's so much random error. Then the second thing is when you have less bias in your study, that is you have less selection bias, less information bias, and you've taken care of confounding, then you increase something called validity. A good study, ideally, should be both valid and precise. Okay, it should be valid. There should be no fatal biases. And it should also be large enough to measure what you're measuring with precision. That would be a dream study. A large, valid study. Large, valid, and precise study is the best type of research study you can come up with. So now the question is, some of you may ask, so I'm reading a paper on COVID that I just received, sent to me as a press release. What bias do I look for? Well, the answer depends heavily on what type of a research study it is, which is why you need to understand the various types of epidemiological studies. Is it a randomized trial? If it is a randomized trial, then I will tell you, look for issues around how randomization was done, what was double blind, was it single blind, so on and so forth. If you tell me, oh, I've been given a case control study, then I will tell you to look for different things. I will no longer ask you about randomization or blinding because those things are irrelevant. I will look for how exactly cases were recruited, whether the controls were a fair sample of the population from which cases came, was confounding adequately addressed or not. Those would be really gigantic issues in an observation study, right? Which is why if you look at the folder, we have for each study design, specific critical appraisal questions put in a Word document for you to take and use, okay? So feel free to look at any of these critical appraisal worksheets. This is what epidemiology students do, right? They will take a paper and they will take the paper apart and critically read it using a template of one of these, and they will depend entirely on the study design. Critical appraisal template for a randomized trial will look very different from a critical appraisal template for a diagnostic study, okay? So study design is really critical. So even understanding what type of a study am I reading or looking at is quite critical because that guides you towards what biases are common in each of the study design. So As I mentioned at the start, every single epidemiological study ever done, including by me, will have bias. Okay? We try hard to reduce it. If we can't eliminate it, we at least try to adjust for it in our analysis. But there is nobody alive or dead who can claim that their research was free of bias. There is no such thing. Okay? Bias is there in every single research study. It is merely a matter of how bad it is, and can we acknowledge it, and can we adjust for it in our analysis. Okay, so an epidemiologist I know, Ellie, has produced these very cute cartoons on various types of biases, because the COVID pandemic is throwing all sorts of bullshit studies in the public domain, and we are all gasping in terms of how bad it can get. So here is something cartoon that she's used. Exciting COVID study, but a super biased study sample, right? When you say it's a biased study sample, you are in the domain of selection bias. Selection bias is the first big thing we worry about, okay? So what exactly is selection bias? Let me illustrate with an example first. This is a famous study, COVID study. I don't think it's published in full. It's just a preprint at this time, on what is the antibody prevalence to COVID-19 in California, okay? This is the famous Santa Clara County study. So the idea was, we don't know how many people in a certain population have been exposed to the virus and have antibodies to them. We only know those who are really sick and who end up in hospitals, but it doesn't quite tell us what is the base of the iceberg, right? Confirmed cases in the hospital are tip of the iceberg, as we saw last time. What is the base of the iceberg? How many people in Uganda or Kenya have been exposed to the virus? So one way to test that would be to go do a random sample of the community, people at home, and then take the blood sample and send it to see whether there's an IgG or IgM antibody in the blood. That's called seroprevalence. Serum means blood, prevalence means prevalence of the infection in a population. So that's what these guys tried to do. How did they recruit people in Santa Clara County in California? That is the question to ask under selection bias, right? Now, how do you recruit? So in this case, here's what they did. They put out an ad on Facebook. So it's a social media based recruitment. They put out an ad on a Facebook and say, if you are a resident of Santa Clara County, if you want to participate in our antibody study, you click here and then you register as an interested participant, and then we'll contact you. And then they will invite these people to come to a certain location and give a blood sample for the antibodies to be tested. Now you have to pause here and say, is this sampling method a good representation of the Santa Clara County? That is the question to ask. So in the end, they ended up with some 3,000 people who were recruited through the Facebook, and they found that 1.5% were positive on the antibodies, okay? But is that result valid because you are worried about how they recruited people? Now, recruiting from Facebook, what does that mean? You have to be on Facebook, okay? Now, if I asked you, how many people in Tanzania or South Africa are on Facebook? I mean, you may have lost a huge chunk of your population if you used Facebook to recruit people in an African country, if people are really not on Facebook. Could it be that if you are on Facebook, you also means that you have maybe a smartphone, that you're more affluent than the rest of the population? Could it be that you have time to go on Facebook, right? Maybe people who are sitting at home, people who are unemployed, people who are old, are more likely to be opening a Facebook ad and respond to an ad, right? Who is the person who gets into the study through the Facebook ad is what we are really debating here under selection bias, right? And in this case, the authors themselves admit that recruiting through Facebook probably attracted people with some COVID symptoms because they are worried, or they had somebody at home, or they were in contact with someone with COVID and they want to know whether they are antibody positive or not, you end up with a very unique group of what we call the worried well. Worried well means they are well, but they're worried because they have some factor that makes them think that they may have been exposed to COVID. And then you end up with a whole bunch of people who are worried well. That can skew your sample towards a different direction than you would if you did a random sample. So an ideal sample would have been a completely random sample of Santa Clara County using the census or using the voter registration database or using some other method. But this Facebook-based recruitment really raises a lot of concerns about the validity of the sample. And they also admitted the study had relatively few participants from low income and minority population. That is a dead giveaway that this is a biased sample, right? So you've lost low income people, you lost people who are not on Facebook, you lost people who may not have smartphones, and you have overrepresentation of the worried people who thinking they may have COVID. That's how the sample gets distorted. This is a classic selection bias example. And there's a beautiful article on how not to do an antibody survey for COVID-19 based on the Santa Clara County example. Okay, so please read it if you want to understand exactly what is problematic with this particular study. Okay, here's one more, hot off the press. So this is a headline in an Indian newspaper 2 days ago, okay? Coronavirus, nearly 15% of India's population may have antibodies, shows private lab data. Oh my God, what a bullshit headline to write. In every single way, this is bad journalistic reporting, okay? First of all, where did the data come from? It's unpublished. It is not even a preprint. It is one guy's tweet, okay? So here is a guy who is the head of a private lab in India. Look at his antibody Velumani, right? That's his name. He's called himself Antibody Velumani. His real name is Velumani, okay? He tweeted that my private lab has tested nearly 60,000 samples for antibodies, and we may estimate that 15% of them are positive, okay? Now, how on earth does one private lab's results suddenly say 15% of Indian population is antibody positive? How do you extrapolate from one private lab's data to the entire country of India, right? Based on a tweet, that too. I mean, this is disastrous journalism, right? This kind of tweet should have been shredded to pieces by Indian media. Instead, they've all been writing, oh, 15% of India is infected with SARS-CoV. Terrible, terrible, terrible research, disastrous journalism, okay? Please don't do this. Ask the question, who the heck did you test? What was the criteria for your private laboratory? First of all, in India, private lab means you have to be able to afford the test. No private lab in India is doing anything free for you. And these tests cost money. So you already have an affluent, relatively affluent section of Indians who can even afford a private laboratory. Okay, that's the first point. Minute it says private lab. Second, it's only one lab, and India has thousands of private labs. Okay. Third, if you probed further in his tweets, he says, we have not chosen whom to test. We've only tested those who wanted it. Now this immediately makes you think that these are all worried well people. Why would you go to a private lab and get an antibody test? Because you're worried. You've either been exposed or you think you have symptoms. You have self-selected yourself to even go to a private lab. How can they be representative of India as a whole? Okay. And then he says 80% was ordered by the corporates, companies. These are company employees who the company has sent for testing. Now, that is not representative of India. Everybody doesn't work in corporates. Corporates hire richer people, middle class, upper class. You already skewed the sample. And then 15% was residential societies and 5% was demand of individuals. This is a horribly biased study, and it absolutely cannot represent India. I promise you that. This is the worst form of research to put out. And the whole thing is put out in tweets, not even a publication that we can actually read or critique. Okay? And the Indian media sucks this all up and publishes bullshit headlines like this. We cannot do that, right? Even a basic understanding of selection bias would have exposed how terrible this kind of research is, right? Last thing we should be doing, we should have just completely ignored this tweet. And then he goes on to claim as if 60,000 samples tested somehow guarantees that the statistics are valid. I already told you, I don't care if 1 million people are tested. If the bias sample is biased, then I don't care what the denominator is. Largeness of the study in this case does not guarantee validity. It can give you more precision to that estimate of 15%. But if the 15% is entirely biased, I don't care how precise it is, because it's a useless study as far as I'm concerned. The correct headline for this should have been, one private laboratory that has tested a bunch of rich people who volunteered because of their corporates or whatever, shows that 15% of this group, which is probably worried well or is rich enough to afford a private lab test, they are positive. 15% of Indians positive is complete bullshit. Should have never ever been published like that. Okay. First of all, you don't even take this kind of a tweet seriously. Somebody's tweet is not a research study. I'm sorry. This is not responsible journalism as far as I'm concerned. But Indian media does all sorts of this kind of stuff. And that's why I had to do a whole course on epidemiology for them. Okay. Now let's define selection bias. You've seen two fantastic examples of what selection bias can be. Selection bias is distortions that result from the procedures used to select subjects and from factors that influence participation in the study. So to make it really simple, who gets picked for a study, who refuses to declines to be in your study, who agrees to be in your study, who stays on in your study if it requires follow-up, and whether all of these factors produces a biased, skewed sample that is completely away from the real population that you're trying to sample from. If this study was truly about India, then you needed a nationally representative survey sampling design, not one private lab testing whatever samples were sent to them. That is completely unacceptable for a national survey, okay? A national survey, you disaggregate by regions. Within regions, you disaggregate by provinces or states. Then you disaggregate by districts. Then you come up with a systematic way of sampling districts and then households, within households, individuals. That's called survey sampling design, okay? There are people who've done their PhDs on survey sampling design. This is not a good study for any national conclusions to be made. So that's what selection bias is. So here is a nice example. If you're really looking at the 2x2 table that you saw between exposure and disease, that is the big population from which you are sampling. All you have is a small 2x2 table. The big 2x2 table is if everybody in India were sampled, which is impossible. But what we have is a small study with a small number of people relatively. The question is not that we have a small study. The question is somebody from each of the cell A, B, C, D have a fair chance of entering the study sample? Is the sample 2x2 table, the distribution of A, B, C, D cells, faithfully capture what the A, B, C, D distribution will look like in the mother population from which we are sampling? That is an unbiased sample, right? The cell could only be 1/100th of the mother population. I don't care. But the fraction that each of the cells gets should be a fair representative of the mother population's 2x2 table. Then it's a fair sample. And if you have an unfair sample, this is how it will look like. For example, in this study, small study, too many people in cell A got in. Okay? There was oversampling of people from cell A. Cell A is exposed and diseased. If too many people got in who are exposed and diseased, then your 2 by 2 table that you get from your study has an overrepresentation of one cell. In this example, it's cell A. But in another example, it could be cell D or cell C. If you have a skewed sampling fraction entering your small study, then you really have a bias in your study. Okay, so let's go back to the worried well issue. If the people who clicked on a Facebook ad were the worried well people, that is, people who are well apparently, but they're worried because they have a friend who had COVID, they had a wife who had COVID, or they think they got exposed somewhere, they're worried, okay? So let's give you another example. Let's say somebody put up a tent in the middle of a busy street in Nairobi and said, come into this tent and we will test you for diabetes, okay? Who's likely to show up in that tent and get tested for diabetes? People who either already have diabetes and they want to know what their blood sugar values are, or somebody like me. I am a worried well when it comes to diabetes. Why? Because my dad had diabetes and died of diabetes. My dad's brother had diabetes, they died of diabetes. I have pre-diabetes. I don't have diabetes, but I have pre-diabetes. I am a classic example of someone who's worried about diabetes. And if there's a free camp for testing blood sugar, I will show up there, right? Because I want to know whether if I can get a free blood sugar and to check on myself. So I am a beautiful example of a worried well for any diabetes study. Now, if lots of people like me end up in the tent, you will get up with a very high estimate of diabetes in Nairobi. That's because the whole study is biased the way people in Nairobi were recruited. Same thing with the Facebook example. Now you see, instead of all cells having equal fraction, you have a massive number of people from cell B entering your sample. Now, who is cell B? They're not diseased. That's why we call them well, but they're worried. So they may be exposed. Okay. So cell B is exposed, but not diseased. Now that group is overrepresented in your study sample, which is probably what happened in the Santa Clara County Facebook study, or this diabetes camp in the midst of a Nairobi busy district for diabetes would all be examples of the worried well getting in. You have to anticipate that certain types of sampling will overrepresent some groups than the other groups. It will not be a fair sample. Okay, all right. Now, selection bias in randomized controlled trials, and I will speak more about that next week when I cover randomized controlled trials. Selection bias in a randomized controlled trial is a huge issue, and it happens right at the time we're recruiting people and allocating them to the various groups. For example, remdesivir against placebo, hydroxychloroquine against something else. At the time of allocation of people into the 2 arms or 3 arms of a trial, if you are not careful, then what you will do is you will cherry pick some people and you will put them in the treatment group, or you will cherry pick some people and you will put them in the control group or placebo group. In an ideal randomized control trial, the person who is deciding who gets which treatment should have absolutely no control on deciding on who gets what. It should be a truly random process, okay? But some forms of randomization are very vulnerable to completely subverting the true need for randomization. Okay, I'll give you an example. In the past, they did a trial on thrombolysis. Thrombolysis is clot busting medicines for acute myocardial infarction. And the trial, this was many years ago. Now, hopefully nobody will do such things. But the trial was, if you came into the hospital with a heart attack on Monday, Wednesday, and Saturday, then you get into the treatment group. If you came to the hospital on a Tuesday or a Thursday or a Saturday, right, the alternate days, then you get the placebo, okay? This form of randomization is called alternating, right? Alternative day allocation. Monday, Wednesday, Friday, you get something. The remaining days, you get something else. Now, on face of it, this looks like a reasonable strategy, right? But the problem with this approach is everybody in the hospital will get to hear that on certain days, you're likely to get some new fancy drug. On other days, you probably will not get that drug. So then what people will do is that they will start subverting this process. The doctor might say, the treating doctor, who may not be part of the study team, the treating doctor will say, you know what? Don't come on Mondays to see me, please. Always come on a Tuesday, because the doctor may be pushing this particular or his or her patients into one group or the other, right? People start making, a nurse will say, no, 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 I want you to come on a Friday because you have a greater chance of being in this group than the other. So all sorts of crazy shenanigans happen, and then you end up with a really bad bias sample. Okay, so the people doing the allocation to treatment or control should have absolutely no ability to interfere with the randomization. Okay, so next week I will tell you more about, I'll give you more examples, and I'll also tell you what is the ideal way of randomizing. What I just showed you, the alternative scheme, is a bad idea. Okay, what we should not be doing in a randomized control trial. Cohort studies also have selection bias. Okay, here's an example. In the past, they did lots of cohort studies on hormone replacement therapy treatment among women, right? Hormone replacement for menopausal women or perimenopausal women, to see whether they are less likely to have heart disease and so on and so forth. But then later on, it became clearer that all these cohort studies had a major selection problem. And that is called a healthy user bias. Who is likely to go on to hormone replacement therapy? They found that it was mostly wealthy women, women who were more health conscious, women who were thinner, women who were more physically active, women who had higher socioeconomic status, had better access to healthcare. So you already have a group that is self-selecting itself to go on to hormone replacement therapy. Not everybody decides to go on hormone replacement therapy. So if you take a bunch of women who are already wealthy, who are already health conscious, who are already thin, who are already exercising, probably not smoking, and then you follow them up to see how many of them have end up with heart disease, you will get a lower incidence of heart disease because they're doing all sorts of good things. But that may be nothing to do with the hormones they're taking. They've selected a certain unique group to even get onto hormones. And it's that rather than the real hormone that's making a difference. And this is called selection bias at entry into a cohort study. There is also something called the healthy continued bias. Now, even if somebody starts on hormone replacement therapy, who will stay on hormone replacement therapy for life, right? All of us are terrible with taking medicines for a long time. I'm taking metformin every day for my pre-diabetes, and it's a big task for me to take medicines because I'm not sick, but I still need to take it, right, to prevent diabetes. So the healthy continuer bias or a healthy compliance bias or a healthy user bias is someone who is determined enough to stick on hormone replacement therapy. And that is a very unique group compared to those who decide to drop out after a few weeks, a few months, right? So these are all the biases that we worry about in cohort studies. And you also have biases in case control studies, which I will discuss next class, okay? In a case control study, who you recruit as cases and who you recruit as controls can make a night and day difference between a biased study and an unbiased study, okay? Here is an example. This was a very famous example of bias. Study published in the New England Journal of Medicine in the 1980s, okay? Coffee and cancer of pancreas. This study declared, and by Harvard University, no doubt, no less, that coffee drinking increases the risk of a cancer of pancreas. And it created a shock wave in the community because everybody was very worried that this is a huge deal, right? If coffee can increase the risk of pancreatic cancer, that is just a terrible situation to be in. Turns out later that this study had a major selection bias, right? In an ideal world, people with cancer, without cancer, that's the case control study, coffee drinkers, not coffee drinkers. That is the exposure we're looking at. Who did they select as controls? Cases where people with pancreatic cancer in a certain hospital. The controls were other gastrointestinal disorders in the same hospital, but did not have pancreatic cancer. Okay. Turns out that if you had other gastrointestinal disorders, for example, peptic ulcer or dyspepsia or some other colorectal cancer, whatever, if you take all other GI disorders, those people had already cut back on their coffee drinking because they found it difficult or they've been advised not to drink coffee. So you ended up with a biased group where this particular cell B, okay, this particular cell B was seriously underrepresented. And therefore, that resulted in a biased odds ratio, which made it look as if coffee drinking was dangerous for pancreatic cancer. In reality, coffee drinking is not associated with pancreatic cancer. So this is a beautiful example of selection bias because of who they ended up selecting as controls. Okay, and then I already showed you with Santa Clara County that you can also have selection bias in cross-sectional studies. Okay, survey sampling biases, a whole bunch of biases that can come. For example, if you go door to door and you ask someone to participate in a study, how many of them will say yes and how many of them will say no? If 50% of the people you contacted said no, then did the 50% who agreed to be in your study, are they even representative of the population that you sampled from, right? All of us would sometimes get phone calls asking us to be participating in some study or the other. But who agrees to be willing to give their time to a telephonic survey, right? I switch off my phone anytime I get those calls because I don't have the time to participate, right? You end up with a very skewed group depending on how the survey sampling is done. So non-response, if you heard of non-response bias, that is a form of selection bias, right? So can we fix selection bias? Well, at some level you can't because you've already selected those people into the study, right? But if you look at the Santa Clara County, they've done some adjustments based on the mother population they sampled from and the sampling fractions that they had in their study. So this is an example of how you can potentially fix it if you knew what's the distribution of A, B, C, D in the mother population, what is the distribution of A, B, C, D in the study population, and if you knew what fraction of people from the bigger cell A got into the smaller cell A, then you can adjust for what we call as sampling probabilities. And that's what the Santa Clara County researchers tried to do. They found that they had underestimated low-income populations or minority populations. So they kind of overweighted them in the analysis, right? So you can try and do some adjustments if you really knew what was the true distribution of some things in the mother population compared to your study population. But selection bias is best avoided at selection. If you have a fatally biased sample, then it's impossible to recover that. Like that Indian study of a private lab is fatally flawed for India. It can never, ever represent Indian population. So it's a complete disaster. No amount of post hoc adjustment can fix that study. All you can say is one private lab tested a bunch of people. Here's the type of people who got tested. And this is the antibody prevalence among them. That's about all you can say from that study. Can never generalize that to India or even all people who seek care in India's private health sector cannot be generalized to. Okay, so before I move on to the information bias lecture, I would stop here and ask you if you have any questions for me. Chido?
Hi, Madhu. We've got a lot of really interesting questions. So the first one that I will touch on, the question is, in Africa, most studies are dominated by male and female single women, unless the target group is specific. Married women do not show up because of responsibilities, and some require approval from their husbands. Do we say these are largely biased too?
Absolutely. Absolutely. I'll give you a great example. When I lived in India, I did research in some of the Indian villages. If you go to an Indian village, say at 10 o'clock in the morning, you practically find no men at all because they've all left to work in the fields. They're all farmers. Okay. So they've all left at the crack of dawn, 5 a.m. They're gone. Okay. So who is at home at 10 o'clock in the morning? Women who may not have gone to work. Even women go to work in the farms. Okay. So either they have women with small children, or they have old people, or they're sick people, or they're people with some disability. Okay. You end up with a very skewed sample depending on how you do the study. So we all had to go to those villages either early morning before they left for the fields, or we had to go in the evening when they come back home for dinner. So this is a very challenging study to do. Same thing here, right? Imagine doing a telephonic survey in Canada at 11 a.m. on a Monday. Who are you going to find at home? Everybody's gone to work, right? Kids are at school. Everybody's gone to work. First of all, nobody will even answer the phone. But if at all somebody answers the phone, it may be sick people, elderly people, people who are disabled, whole bunch of issues come in. So yes, the answer is depending on how the study is done, you must ask, is this a fair sample that is representative of the population? If women are missing, or if men are missing, then you have to really query the validity of the sample. Next.
Okay. The next question, I'll join two questions. The first one is, I know most epidemiological studies are quantitative in nature. In qualitative research, samples are usually small by design. Where do you draw the line when it comes to bias? And then the second one, which links to the same one, is, does this mean that studies done with a small number of people are never accurate?
A small number of people are never
accurate. So I think it's
accurate.
Referring to they're more biased.
Yeah. Okay. So both are great questions. So firstly, this entire course is quantitative. Okay. Because epidemiology, by definition, is a hardcore quantitative discipline. We do not deal with qualitative research at all. Okay. So nothing I'm saying is valid for qualitative research. Qualitative research is a whole another level of training, which we don't have, and we don't see ourselves as qualitative researchers. Qualitative research absolutely deals with much smaller numbers of people, and they do in-depth interviews for hours. They do multiple interviews with the same set of people. They use focus groups. They use a whole slew of techniques before they figure out what they are trying to estimate. And they're not really looking for quantitative numbers in a qualitative study. They're looking more at people's perceptions, people's willingness to change, or behavioral issues or psychological issues. So the whole issue of sample size there is not seen the way we approach a sample size. We do an epidemiological study precisely to get a number, and we want to estimate that number with some precision. But that's not what qualitative researchers are trying to do. They don't care about the numbers, okay? So completely different sets of issues. Small studies have huge random error, right? You let's say you did an antibody study in some part of Ghana, okay, in Accra. So you only had 100 people in a certain city or town. You might get an antibody positivity rate of 10%, but the confidence interval might vary from 2% to 40%, right? Of what use is that study? You're basically saying somewhere between 0 and 40% of Ghana people in a certain place might be infected with COVID. The utility of that work dramatically drops because you have such a fuzzy confidence interval, right? Imprecise estimate. But that's also an added issue here, because in addition to the small study in Ghana, it's also a question of how these 100 people were selected, right? If that is also biased, then you have poor precision and you have poor validity overall, the study is completely useless. Next.
Okay, I'm going to combine two questions again because they're quite similar. So this one says, how should we report on biased studies? Do we just ignore them or let the public know about it, and how? And then the linking question asked by somebody else is, as a journalist writing about the private lab in India's results, how do you write that headline better to reflect bias but still show their results?
Yeah, so firstly, if you're reporting on a study and if the study has major biases, then you, as a journalist, I would argue, have an obligation to point out to your readers that this has got some serious issues, right? Either you do it yourself or you get experts like me or others to critique it and tell you what is wrong with the study. But to present the study results without talking about the bias in the study is simply unacceptable, right? We would never do that in epidemiology, right? We would always say, here is what the study found, but here is a selection bias issue, here's the measurement issues, here is the potential for confounding. We qualify that by talking about all the problems. And I think that's the kind of reporting that has been largely missing in this pandemic. Too many journalists are accepting research at face value. They're just taking whatever is given to them and they're pretending like that's it. That's truth and that's fact. That's what these Indian journalists did with that headlines on 15% of Indians being reported. I'm astonished that they wouldn't even ask a question. How does one private lab's data, that too on a tweet, equate itself to 15% of Indians being infected? I mean, where is the critical thinking here? It's just pathetic journalism, right? Complete rubbish journalism. And why would you even give somebody's tweet that importance? Is that a study, right? So I would have just not even reported on that tweet, to be honest. If I did report on that, I would say private lab CEO tweets biased numbers and makes conclusions about India's seroprevalence. That would have been my headline. Okay?
Yes.
Can we move on?
If there's time, I think I can link two more.
Let's take them more in the Q&A later.
Okay, perfect.
All right, okay, next.
Yes.
So selection bias is all about who gets into the study, who gets invited to be in the study, who stays in the study, who says yes, who says no, all of that. Information biases, you have successfully recruited your sample, whoever they are. Let's say we've done it well. There's no selection bias. Now we're measuring actual things on people, right? We're checking the blood, we're checking the blood pressure, we're checking their antibodies, we're asking them about their sexual behavior, we're asking them about risk factors, we're asking them about family history, we're asking them what medicines they've taken. Now we are in the measurement realm, okay? Measurement. This is critical in epidemiology, right? Here's a beautiful cartoon from Ellie. Exciting COVID study. Oh, well, but it's all just measurement error. That means you could have bad outcomes in a study, completely biased, fatally flawed, because the measurement tool was terrible, right? The way we measured it, what instrument you used, how much error is there in the instrument, whether we measured the cases and controls equally or not, all of that becomes critical. And that's why we call this information bias, also called measurement bias. Okay, it's a fact of life. Nobody in the world, including me, has ever done a study where we measured things perfectly. I don't care what it is, it has measurement error in it. Every single variable in everybody's data set is measured with some degree of error, right? The question is, how bad is the measurement tool? How much noise is there in the data set? And can you make any sense out of the data at all? Okay. And just to kind of drive home the point on how widespread measurement error is, I will tell you this anecdotal story. Years ago, when I was a resident in India, I told you we were working in villages. So my boss asked me to do a survey, go house to house and collect some data from people in the village. So I went with my beautiful questionnaire, right? And I was a young first-year resident. I was very confident of myself. So my first participant was a woman who looked very old, okay? She looked, I mean, her face was wrinkled. She had long ears. Her earlobe was, coming to her neck. She looked really old, okay? Seriously wrinkled face. So I started asking her, what's your name, right? And then I said, what's your date of birth? Right? Date of birth was on my form. She started laughing at me, okay? I said, why are you laughing? What did I ask you? I just asked you for your date of birth. She said to me in the Indian language, she said, son, I have no idea what my date of birth is. I don't know what my date of birth is. So I said, do you know your age? She said, no, I don't know my age. So she said, you look at my face, you decide how old I am, and then you put it on your question. Okay. I said, oh my God, I can't even get age in my study. Age. I can't measure accurately in this context that I was working on, right? Lots of people in many parts of the world simply don't have date of births or do not measure know their age. What do? You can't even get age right. Okay. So then I had to go running to my boss. My boss was a very, very well-known, outstanding epidemiologist. He did an entire 10-minute discussion with her. And she said, okay, you don't know your age, but do you know whether you were alive when India attained independence? Was your mom alive when India attained independence? How old was your mom when India achieved independence? You know that big flood that destroyed your village? How old were you then? He used 18 questions to finally triangulate her age. Just age required that much amount of effort to get it right. Which means, imagine asking questions like going to Nairobi or a township in South Africa and doing a study on HIV and sexual behavior. Just imagine asking a young man, how many sexual partners have you had? How accurate do you think that information that you will get by asking a question? How many sexual partners have you had? 2, 10, 20? What is the measurement error in that question, right? And this is not an easy study to do. And anybody who does this study on sexual behavior in whichever context will have to think 20 times on the validity of the measurement that's going to come, right? Because there is stigma. There's tremendous stigma, right? Nobody even wants to be in an HIV study. Men might answer the question very differently from women, right? Married women will answer the question very differently from unmarried women. Young girls may answer it very differently. Whether there is a husband in the same room or not, when the question is being asked, can completely change the response, right? These are all things to worry about when we talk about measurement error, right? That's why this is such an important issue. So here is even things like laboratory tests have measurement error in them, okay? Even a lab test cannot be taken for granted. A question on sexual behavior is not even a lab test. It's a question, right? But imagine even a lab test. So here is a study, okay, on cervical cancer and pap smears, right? Pap smears, you take a sample from the scraping from the cervix from a woman, you put it on a slide and you send it for cytology or pathology, okay? They found no association between HPV positive and HPV negative samples when it comes to risk of cervical cancer when the pathology was done in Brazil, right? That's what the study was done. The study was done among Brazilian women. But the same slides, they then brought it to Montreal. And they had a fancy laboratory here. The same slides were read again by an expert pathologist in Montreal. Boom, suddenly you see a beautiful association. HPV positive samples had a much higher risk of cervical cancer than HPV negative samples. Same people, same slides, but read by two different sets of experts in two countries. Made a night and day difference to the study, right? That's because the pathology reading in Brazil was just not good enough. there was too much measurement error in the pathology reading of slides in Brazil. And when it was repeated in Montreal with a much better reader, they found a massive difference. Okay. So this is an example of measurement error, and it can totally change your study results if you don't worry about it. Okay. And it turns out that in the early days, so today we know, all of you know, that human papilloma virus is very strongly associated with cervical cancer. Okay. Spectacularly strongly associated, which is why we have a vaccine to prevent cervical cancer. But in the early days, I'm talking about the 1980s, 90s, I'll use my pointer. So you can see in the early days, the odds ratio for the association between HPV and cervical cancer was strong, but not that strong. But as they improved the pathology and detection of HPV, you can now detect HPV using very good molecular tests, PCR tests that we use for COVID right now. The association became stronger and stronger and stronger. So today, the association is well over an odds ratio of 100. 100 is a spectacularly strong odds ratio, right? HPV positive people 100 times more likely to end up with cervical cancer than HPV negative people, right? So as the measurement tool improved, you see a beautiful increase in the strength of the association, right? Which means a bad tool can sometimes make you lose the real association, right? The tool is too noisy to pick up a real signal in the data, right? As the tool becomes more refined, you can pick up the signal better. So think of information bias as noise versus signal, right? There's always noise in the study data set, but if the instrument is sharper, then it can more accurately pick out a real signal in the data set, okay? So what's information bias? Bias in an estimate arising from measurement error, okay? And it occurs at the time of data collection. It occurs after selection, right? Selection bias is first because people are selected into the study. Once people are selected into the study, information bias or measurement bias can skew the results that you get at the time of data collection. Now, in an ideal world, remember HPV, positive, negative, right? In an ideal world, everybody in the world will be positive or negative. All the positive people will have one answer on a test. All the negative people will have another answer on the test, and there will be zero overlap between the two populations, right? That it will be straightforward to tell apart a diseased person from a non-diseased person. Right now, we all wish we had a beautiful, simple test which can immediately tell us who has COVID and who doesn't have COVID. Imagine if we had that, how much more beautiful our response in this outbreak would be. Right now, we're all struggling because we quite can't tell who has COVID, who doesn't have COVID, who's been exposed and who's recovered, who's sick, who's not sick. It's a nightmare to figure it out, right? But in an ideal world, this is how it'll look like, right? So the diseased and the non-diseased people will have completely different values on the test, whatever the test is, and there will be no overlap between the two, right? In reality, this is what we work with. Whether it's antibody levels, whether it's blood sugar levels, whether it's cholesterol levels, whether it's blood pressure levels, whatever it is, there's always an overlap between the diseased and the non-diseased people, right? Which is why every single test we use in medicine or public health has its own measurement error. There will be some diseased people who will be wrongly considered as healthy, and there will be some healthy people who will be incorrectly classified as disease. Wherever you draw the cutoff, antibodies, blood pressure, cholesterol, blood sugar, hemoglobin, I don't care what it is that you're measuring, any place you draw a cutoff. For blood pressure, the cutoff is 120 over 80, right? Wherever you draw the cutoff, you will misclassify some people. Misclassification means a diseased person will be incorrectly labeled as non-diseased. A healthy person will be wrongly labeled as diseased, right? And this is so easy to understand. You walk into a clinic, you take a blood pressure, and suddenly your blood pressure looks abnormal. Go back the next day, your blood pressure is now back to normal, right? Is that because of the stress of going into a clinic, you suddenly have a slightly higher blood pressure? Same person, two different blood pressure instruments give you two different answers, right? Every measurement tool has its error, and then on top of it, we put a cutoff, we end up with more error. So here is a nice paper by our research team at McGill, published in BMJ. How accurate are the serological antibody tests for COVID-19, right? They did a meta-analysis, which Taryn will cover more next week. And you see the pooled sensitivity and specificity is something I will cover myself next week. For now, sensitivity and specificity of a test is accuracy of a test, okay? Pooled sensitivity of the ELISA test for antibodies was only about 80%. What does that mean? It means if you have 100 people who truly have COVID antibodies, ELISA only picks up 80% of them. You missed 20% by doing an ELISA, right? So whatever prevalence you get, the real prevalence must be higher because ELISA is only picking up 80% of truly COVID infected people. Pooled specificity is very good, right? It's about 97 to 100%. So specificity is not a problem. In other words, if a ELISA test for COVID-19 antibody is positive, then in all likelihood, it's a true positive. It is not a false positive. The problem with ELISA in this study is the sensitivity is relatively low, only about 80%, which means 20% of people with COVID antibodies will be missed by this particular test, okay? More about this next week when I talk about diagnostic studies, right? Then information bias in randomized control trials, right? Randomized control trials can also have information bias. I'll give you a beautiful example. They did a study on vitamin C, large doses of vitamin C, to see whether it will help with common cold, okay? So they randomized people to vitamin C and to placebo, right? And then they had to see what happens to their cold symptoms and so on and so forth. And I have published a case study on it. You're welcome to go and look at it if you wish. Here's what people did. Vitamin C is an acidic substance, right? Vitamin C is ascorbic acid, right? So when you taste it, when you break the vitamin C pill with your tongue, you can tell whether it's vitamin C or not. So although the trial was blinded, that is, people didn't know whether they got vitamin C or whether they got a placebo pill, people were actually testing it out to see whether they are on this or that. Now, the minute I know I have actually swallowed a vitamin C, then my reporting of the cold symptoms might be very different than if I knew I was taking a placebo or a sugar pill, right? So this is accidental unblinding. And if you're not blinded, then that can influence your reporting of symptoms, right? So in a randomized control trial, one reason why we blind people, and you will learn more about that next week, is to protect the whole randomization and to make sure we collect information equally, okay? So blinding is very helpful. In this case, even though it was a strong randomized trial, they messed up because people could find out whether they were taking this medicine or that medicine, okay? Case control studies also have a certain bias that we call recall bias, okay? I'll give you a good example. One of the popular ways of checking whether a certain type of medicine or vaccine causes congenital malformation, right? Babies born with birth deformities, is to take babies with birth deformities and ask the moms, okay, so, what exposures did you have? What medicines did you take? Did you take any vaccine? Did you come in contact with somebody who was sick or not? So on and so forth. And then who is the control baby? Baby that was born healthy, right? The case babies are babies with congenital birth defects. Control babies were born healthy, right? Invariably, they found that moms who had a baby with deformities were remembering very differently what they did compared to a mom who just had a healthy baby, right? Why? Because if you had a baby who's had a birth defect, you really think hard, you ruminate, right? You really rack your brains to say, what did I do wrong? What medicine did I take? Oh, did I drink some alcohol when I was not supposed to have taken alcohol? Did I smoke when I should not have been smoking? Or did I come in contact with somebody who had measles? The information you get is very different between a case mom and a control mom. And that can itself skew the study results, right? We call that information bias or recall bias. You can get completely different exposure information from a case and a control, and that can skew your odds ratio away from the valid true estimate. Okay, we call that recall bias. So there are many ways to deal with information bias. Use the best tool possible. Look at the sensitivity, specificity of each question or each tool you're looking for. And if you know what it is, you can try and adjust for the sensitivity and specificity. Use blinding as much as possible, right? Train people to ask the questions consistently and carefully. Use a good questionnaire compared to a bad questionnaire. There are people who are really good at questionnaire designs, right? And then try and collect some data on sensitivity, specificity of a test so that you can actually adjust for that in your analysis. Time for one or two quick questions, Chido?
I think the session that you've just had answered the two questions that I wanted to ask.
Okay.
From before, but maybe, yeah, I think we can carry on.
Okay.
Yeah.
And if there's anything more, we can answer it in the Q&A session. Okay.
Yes.
All right. Last, bias, confounding, really important. Okay. So here's another cartoon, exciting COVID study, but it's all confounded. Okay. Confounding by indication is a type of confounding. So let me explain what confounding is. So I'm going to start off by telling you this very frustrating headline in the magazine Economist. Okay. I mean, Economist is a world famous magazine, and they wrote this headline which really got me pissed. Smokers seem less likely than non-smokers to fall ill with COVID. This may point towards a way of treating it. Okay. Again, I think this is a seriously irresponsible headline by Economist, right? Based on one observational study with huge potential biases. To have a magazine like Economist write this headline, and how dangerous is this headline, right? We've spent years fighting smoking, right, in public health. We found mountains of evidence that smoking is dangerous for lung cancer, it's dangerous for heart disease, it's dangerous for every damn outcome we're looking at. And then you send a message that smoking might be beneficial against COVID. I mean, what the hell, right? This is terrible reporting. And this is just absolute bullshit. And I tweeted to economists saying that they should take this down because this is rubbish, right? And then they look at this, Telegraph, bald men are at higher risk of COVID, research finds. And I'm like, oh my God, when is this rubbish going to end, right? This pandemic is full of this kind of bullshit reporting that has got people with no serious analytical ability and researchers who are not even asking basic questions. I mean, last week there was this paper published, and we'll talk about that next week, on how eating cabbage and cucumber will protect you against COVID, okay, based on ecological studies. Complete rubbish stuff coming out of the pipeline, okay? So both these studies, smoking as well as balding, can be explained by a very important bias called confounding, okay? Now, what's confounding? The definition is confounding is called confusion or mixing of effects. The effect of the exposure on a given outcome is mixed together with an effect from a third variable or another set of variables leading to bias, okay? Let me explain this visually first. So here is a spectacular, beautiful example from a textbook by Rothman, okay? Here in the early days, I'm talking about the 1970s, 80s, they saw an association between birth order and Down syndrome. All of you know what Down syndrome is, right? Down syndrome is a chromosomal defect. The baby is born with Down syndrome, and you can tell the eyes are well apart, right? There are some clear signs and features. And then if you did a chromosome analysis, you will immediately know that it's Down syndrome, okay? And so they found that there was a link between birth order and Down syndrome. What is birth order? First baby, second baby, third baby, mom had a fourth baby, mom had a fifth baby, right? So the greater the birth order, fourth baby, fifth baby, greater the incidence of Down syndrome. Can you see that? Clear, nice relationship. Greater the birth order, higher the risk of Down syndrome. Now you could stop here. You could publish this and say, okay, it's not a good idea to have 4 kids or 5 kids, because then you will end up with Down syndrome. Okay. But this is a completely biased picture, because you're not asking whether it's birth order, whether it's something relating to birth order that is causing this linear trend between birth order and Down syndrome. Now, I'm going to show you a second picture from the same study. Now, instead of birth order on the x-axis, you have mom's age on the x-axis, right? Mom's age is under 20, mom is 20 to 24, mom is 25 to 29, so on and so forth. You see the minute mom's age starts hitting mid-30s, 35 to 39, 40 plus, the risk of Down syndrome just shoots up. Can you see that? So now you have a beautiful relationship between mother's age, maternal age, and Down syndrome. So now we have a problem, don't we? We have this data, which is a simple 2x2 table analysis of birth order and Down syndrome, which shows that birth order, increasing birth order, might be associated with Down. And then now you have a second 2x2 table showing that maternal age is associated with Down. Which of this is true? The answer is we will never ever be able to tell which of this is true unless we put them into a multivariable analysis, right? We have to bring all of them into the same, look at it from a 3-dimensional perspective. Now we have birth order on this axis. We have mother's age on this axis. And then the vertical axis is risk of Down syndrome, right? This is what we call stratified analysis. We stratify by chunks of mom's age. And in each chunk of mom's age, let's say moms who are younger than 20 years, you see here, whether the birth order is 1, the birth order is 5, there's absolutely no association with Down syndrome, right? Okay. Now let's take mom who's age 20 to 24, nothing. Within that band of moms, age range of 20 to 24, zero association between birth order and Down. Take the oldest mom, 40 plus, nothing, flat line. There is no link between birth order and Down syndrome. But let's flip the order or reverse direction. Let's take birth order of 1 and ask first child, okay? Is there a link between maternal age and Downs, okay? Take a look, the risk is low, 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 suddenly shoots up at moms who are like 35 to 39, and then 40 plus, massive risk, okay? Now let's take a birth order of 5, very low risk at the start, suddenly shoots up between the age of 35 and 39, and then 40 plus, huge risk, right? In any given birth order, there's a beautiful link between maternal age and Down, but in any given maternal age stratum, there is no association between birth order and Down. This exposes beautifully that all along, it was mother's age that is the biggest risk factor for Down syndrome, not the birth order, right? Our inability to tease associations apart when we are presented with this complicated picture, that's what confounding is all about. We think there is an association between tobacco smoking and COVID, but then there is something else lurking behind these that could be causing both and making that association appear out of thin air when there is no association, or it could suppress a real association if there was one. Okay, confounding can be a positive or a negative phenomenon. Okay, now I will explain that using a slightly more visual framework. Okay, imagine there is a water pipe. You see water coming from one part and it's coming out through the other side of the water pipe. Okay, we think that's the exposure, let's say tobacco smoking, and we think there is an association with some outcome. Okay, COVID-19, for example, right? But what if there was, without us knowing, a hidden water pipe where both the exposure and the outcome have some connection to another water source, right? Now you see, if you see water coming here, you don't know whether the water came from the exposure or it came from another source called the confounder, which was feeding both this and feeding both the outcome, right? That's what this confounder problem is all about. The only way we're going to solve that problem, right, is to shut off the confounder. We have to shut off that pipe above, which feeds both, and see whether exposure and association or outcome are still associated, right? This is what we do when we say adjusting for confounding. We fix the confounder to be not variable, which is exactly what we did in the stratified analysis, right? We fix the mother's age to be not variable, or we fix the birth order to be not variable, and then we see whether there is still an association, right? So stratification is a type of adjustment for confounding. And when you fix that and you ask whether there is still an association between exposure and outcome, then the third variable fades from the picture. You've taken care of that confounder. Now, whatever you're seeing is a real association between the exposure and the outcome, right? So if the exposure is between baldness and COVID-19, is age a confounder? Maybe it's not balding at all. It's merely age, because older people are likely to bald and older people are likely to also end up falling sick with COVID, right? That's the kind of questions we should be asking. Did they adjust for critical confounders, which may obscure a real relationship, right? That's what this is all about. Okay, so a confounder by definition must be a parent of the exposure. Parent means the confounder should be strongly causing the exposure, and the confounder should also be associated or causing the disease, right? That's why we say a confounder is the parent of the exposure on the outcome. If that's the case, then it will distort whatever you see as the association between exposure and disease. You might see a strong correlation between E and D, but it's actually C that's causing both. And unless you get rid of that C or adjust for it, you will never know what the true association between E and D are, okay? This problem is confounding. Now let's look at maternal age, birth order, and Down syndrome as an example, right? We first thought that birth order was the one that was increasing the risk of Down syndrome. But we realized later on, it was maternal age. Older moms are likely to have more children. Older moms have an increased risk of Down syndrome. So it's actually maternal age that's the real feeder of this problem that we saw, okay? Now, same thing, look at baldness. Remember, we spoke about balding and COVID-19, right? So you saw an association between balding and COVID-19, which is what that Telegraph headline is all about. But it could actually be older people are likely to bald. Older people are likely to fall sick with COVID. So once you really take care of age, balding may never be an issue, right? In fact, I don't think balding has anything to do with COVID. Now, you've already seen me talk about the counterfactual causal effect, right, in the past. In an ideal world, in a dream situation, we'll have people exposed to tobacco smoking, for example, and then we follow up to see what is the incidence of COVID-19. Then we will have the same people, nothing has changed, all else is constant, but they will not be smoking, right? And then we'll have an incidence of COVID-19 in the unexposed group. If we could get this dream comparison, we're done. We'll know exactly what smoking is doing to COVID-19. Because if this incidence is much higher than this incidence, we're done, right? Then we'll say, okay, the risk ratio for tobacco smoking is 10 times higher than tobacco non-smokers. In other words, the risk ratio of 10 here would mean tobacco smokers have a 10 times higher risk of developing COVID-19 than non-smokers, right? There is zero scope for confounding here because it's the same people at the same time. In one situation, they were smokers. In the other situation, they're non-smokers. All else is constant. Same genes, same environment, they're living in, same diet, everything is fixed, right? The only thing that is different is one group was smoking and the same group was not smoking. But we know that this is never going to be happening in our research, right? We'll never get this dream comparison. So what we can get is this. We have a bunch of people with tobacco smoking history. We follow them up for COVID-19. We would like to see the same group non-smoking, but we can't get that group, so that's hidden, right? This group is hidden. You will never see it. What we do now is get a completely different group who will be non-smoking, and we'll follow them to see what happens to them in terms of COVID-19, right? Now, unfortunately, this group might be very different from the non-smoking group. They may be different age. The sex distribution might be different. The family history might be different. They may be eating different diets. Tobacco or smoking may be linked to more alcohol in this group, less alcohol in this group. All sorts of interesting differences appear between the two groups. Now you're worried that whatever you're seeing may not be a true causal effect. And that is a good worry to have. That's why we'll never be able to confidently tell whether if this group is a poor substitute for this group, the counterfactual group, we are left concerned whether there is confounding. So the confounding is nicely captured. Confounding is present if this substitute cohort of unexposed people are a poor substitute for the counterfactual cohort if we had observed them in real life. Okay. Now, randomized trials are the closest and the strongest design because they kind of get us close to this unconfounded dream counterfactual comparison. Why? Because when we take people and we randomly assign them to treatment and placebo, we make sure by and large that the two groups have similar distribution of age, similar distribution of sex, similar distribution of diet, similar distribution of physical activity, alcohol, anything that you look at. The act of random allocation, randomization, is powerful because it gives you similar looking arms of a trial with similar distribution of various factors. Then we are less worried about confounding, right? That's why randomized trials inherently bias more protection against confounding. Observational studies, on the other hand, people choose to smoke. People choose to drink. We cannot assign that to them. And therefore, if somebody smokes, they may also be doing a whole bunch of other things. And we cannot tell whether it's smoking that it is or something else that's actually causing the effect, right? So randomized control trials do a better job of handling confounding. Observational studies, confounding is always a concern. So if you say, here is an observational study on hydroxychloroquine, I'm already very worried. Because who gets to decide to go on hydroxychloroquine? Who gets to go on steroids? Who gets to be put on diabetes medications, right? People in real world are not making random decisions, right? They're making decisions to take some medicines, or doctors are deciding to give them some medicines based on a whole bunch of other risk factors. Therefore, confounding is a huge concern in real world. I'm going to give you a quick example, then we'll close this lesson. Male circumcision and risk of HIV, right? I'm sure you've all seen, especially in sub-Saharan Africa, where there is a lot of HIV transmission. In the early days, there was a lot of thinking, is males, men who have circumcision done, surgery done, are they more likely to have HIV or less likely to get HIV, right? They'd done a systematic review in the early days, and Tarrant's boss, Jimmy Wolmink, is on this paper, and this was led by a team in South Africa, right? So they found that in this systematic review, they only found observational studies, right? And they were very worried about confounding. So they said, look, we really can't tell. The studies had major limitations and confounding, we cannot quite tell. And here were the confounders that they were looking for. Circumcised men are more likely to be of a certain age or a certain religion, or circumcised men may have different sexual behavior than uncircumcised men, or different condom use, all sorts of interesting confounders, and they never could tell what was going on. So there was a lot of confusion in the literature on whether circumcision is a good thing or a bad thing for HIV risk. And then first ever randomized trial got done. This was done in Africa, and I believe this was done in South Africa. Okay, it's a large randomized control trial, and this study was so powerful that even at the midpoint they had to stop the trial because they found that circumcised men had a huge protection against HIV, 60% lower risk of HIV after the men got circumcised. So here they recruited men and they randomly decided that one group will get circumcision, the other group will get circumcision much later if they want it. Okay, more like deferred circumcision. They found a massive difference. And here you see the circumcision group and the uncircumcised group in this randomized trial. A beautiful comparability, right? Look at the age, look at the ethnic group, look at the religion, look at the number of sexual partners. It really didn't matter. They were fairly similar in these two groups. And that is the beauty and the power of randomization, right? You randomly assign who gets circumcision or not. The men don't select, okay? And in this situation, randomization brings you closer to the dream counterfactual situation. Now, with this level of comparability between the two arms, whatever difference you see between the two groups has to be circumcision. Confounding cannot be an explanation in this trial, right? And they did two other studies, one in Uganda and one in Kenya, with identical study results. Amazing. And both the trials had to be stopped early, for just like the South African trial. And then if you do a meta-analysis of all three, and Taryn will tell you more about that next week, you basically do a weighted average of these three trials, South Africa, Kenya, Uganda, you get a beautiful pooled estimate showing 60% reduction in HIV, which is why everybody now believes that male circumcision is a very good intervention to reduce the risk of HIV. Okay, so that's how we, and confounding is never a concern in these trials, in these three trials, right? Because randomization produces similar groups with similar distribution of all other variables. So everything else is held constant. The only difference now has to be the circumcision, right? So this is an effect that cannot be attributed to any other variables, right? So we can address confounding in the design stage, for example, by doing randomized control trial, or we can need to do a lot of adjustment in the analytical stage, right? Here is an example, hydroxychloroquine randomized control trial, right? So if you see any difference or no difference between hydroxychloroquine and non-placebo, whatever you see is because of the drug. There is no other concern because they are randomly allocated. But look at the observational study on hydroxychloroquine. This is not a randomized trial, right? And then you're looking, and the title itself says observational study of hydroxychloroquine in hospitalized patients. Now they're very worried about it, right? In an observational study, you taking people in a hospital and saying who's already on chloroquine, who's not on chloroquine. The chloroquine was not allocated by the investigators. They just took the data set and they looked after to see who happened to be on chloroquine, who was not on chloroquine, and what is the difference in the COVID outcomes, as opposed to taking people entering the hospital and then randomly giving one half to chloroquine, the other half to some other treatment or placebo, right? And now you see, while the randomized trial did not even mention confounding, confounding was a huge deal in this observational study. And this is straight from the paper. In our analysis, we adjusted for likely confounders, including age, race, body mass index, diabetes, kidney disease, lung disease, hypertension, vital signs, peak flow, and other respiratory function, right? Forced expiratory volume, other inflammatory markers of severity of disease, right? Confounding had to be a massive, massive part of this paper. There's no way it cannot, right? Because the decision to take chloroquine was not randomly allocated, right? So people who were maybe given chloroquine because they were much sicker, or people were given chloroquine because they were of a certain high-risk group, they were older, they were obese. Who knows what factors went into deciding to put someone on chloroquine or not, right? The only way you have to do it is to adjust it in the analysis. And look at what they've written. Despite this extensive adjustment, it is still possible that some amount of unmeasured confounding remains. Very honest way of writing, right? They're saying, look, we tried hard, right? We tried hard to adjust for confounding. We cannot rule out confounding. So whatever we saw, it could still be a biased estimate because of confounding is what they're trying to say. So that's the powerful benefit we get from a randomized control trial. Confounding ceases to be a critical issue the minute you randomize. If you can only do an observational study, then huge amount of time and effort and energy has to go into addressing this problem of confounding, okay? Because people who are on hydroxychloroquine might be very different from those who are not put on hydroxychloroquine. So if you see a difference for chloroquine, you don't know whether it's chloroquine or it's because of something else like older age or diabetes or obesity or something else that's producing a difference between the chloroquine and the non-chloroquine group. Questions?
Thank you, Madhu. The first question that is the direct follow-on to the last section is, how do you address more than one confounder? Supposing if the bold men were also obese and old, in this case, weight and age are confounders. Which one is a bigger confounder than the other?
Beautiful, beautiful question. So in epidemiology, we do all sorts of, we look at prior literature to see which factors are associated with the exposure and the outcome. And then we can do something called a causal diagram to then say, these are more important confounders than the others, right? We also do it empirically. We do a multivariable analysis. You've heard of regression analysis, logistic regression analysis, survival analysis. That allows us to enter multiple confounders at the same time. Okay, we can adjust like these guys did in the last New England Journal paper that I showed you. You can put 10 different confounders in the mathematical regression model and see what happens to the primary association odds ratio. Then you can remove some confounders from the model, you run it again, and you see how that model differs from the previous model. So there's a lot of analytical work involved in how we adjust for confounding. So, but it is possible using modern sophisticated statistical software to look at multiple different confounders at the same time. That's why we call it multivariable regression analysis. Multivariable means multiple variables at the same time. Questions?
This question is on study design, and it is as follows. In view of the double and triple blinding, who is then responsible for assigning participants into the treatment and placebo? What is the role of the researcher/investigator in RCTs? And then just following on to that question is another question saying, is there a difference between control and placebo?
So there's a treatment arm and there's a control arm. The control may be placebo if it's ethically acceptable. The control arm may be the standard treatment. The control arm could be a whole another drug, right? Everything depends on the study. All we can say is treatment against control. Control may be placebo, control may not be placebo, it could be some other treatment. So that's an easy question to answer. Now, going back to the question of blinding, the people doing the allocation between treatment and control, blinding comes much later. You first have to assign the treatment and you have to do it in a very random, non-biased manner, right? Blinding is more about, are you preventing the patients from knowing what they're on? Are you preventing those who are measuring the outcomes from knowing who's on what, right? That comes much later. Selection bias happens at the time of allocation. The people doing the allocation should not look at a patient's face or their profile and then decide, oh, you should get chloroquine, you should not get chloroquine. That's a no-no. That should be done purely randomly, right? So let's not confuse the allocation to treatment with blinding. Blinding comes after. Once a treatment is assigned, you make sure people don't know what they're getting. Okay, that's the difference between the two. I'll explain that better in the lecture on randomized trials next week.
That's all the questions, Madhu. Thank you so much.
All right, folks, I hope that was helpful. Bias is super important in all epidemiological research. And please watch the lecture again, and I will cover more bias-related issues when we speak about each study design next week. So we will begin with randomized control trials, and then I'll walk you through all the potential biases in those study designs as well. Okay, so that's it. And all of next week is various study designs looked at in slightly more detail. Okay, we don't have a huge amount of time with you. Each design could be a whole 2-hour lecture, but for now we have 1.5 hours with you on Monday, and Thursday we need you to give us 2 hours of your time to wrap up and finish everything that we wanted. Trust me, there's a lot of good content coming your way on diagnostic. How do you look at sensitivity, specificity of studies? What is a meta-analysis, right? All of them are relevant in this COVID context. So we will see you again on Monday, okay? And as usual, we will upload the video of this lecture. Plus, we will also, Cheeto and I work on the Q&A based on all the questions you asked, and we'll post it on the Google Drive. Okay, have a good weekend and stay safe. Thanks, Cheeto.
All right.